Good afternoon, everyone.
Good afternoon, Madam Chair.
Why, thank you. We are the Senate Finance Committee. Today is Wednesday, January 25th, 2023. We have a briefing today on health occupations. We will first hear from the Maryland Department of Health. Good afternoon. If you want to come forward, and I don't know who you've brought with you, and I know we're going to hear from the boards in just a moment.
Good afternoon, Chair Griffith.
Can you pull your mic
Oh,
close so we can?
Tammy told me not to touch it.
Did she? Well, I'd go with Tammy. I do what Tammy says.
I know. Good afternoon, Chair Griffith. I'm Kim Link. I'm with the Maryland Department of Health. I'm the senior advisor to the Secretary of Health on health board matters. I'm going to present today generally about health occupations boards since we are new to your committee this session. So thank you for the opportunity today. I have with me representatives from 3 of the health occupation boards. We have the Board of Physicians, the Board of Nursing, and the Board of Physical Therapy. And they'll speak to give you more information about their particular boards, just to give the committee an idea of what boards look like in their own individual structure. I'll stick to the general overview and how they work within the department. May I get started? Okay. Okay, so there are 20 health occupations boards, and as you can see from the slide, I would say A to Z, but it's A to S. A variety of health occupations are represented in these 20 boards. This committee will rarely see, or unlikely to see, bills that affect all of these boards all in one session. However, you'll see many. This session, for instance, I know several bills have already been introduced for chiropractic, massage therapy, social work, professional counselors, physicians, nurses. So quite a few bills will come before you this session that involve or related to specific health occupations boards. The boards license, regulate, and discipline healthcare providers, and their mission is to protect the public. So I'd like to tell you generally the boards, and each of the boards can speak how do they differ, but there are many things that they have in common. Each board has their own practice act, which is their statute that governs their board, as well as their own set of regulations. Each board has its own executive director. They have their own administrative and investigative staff. Each board has board counsel, who are assistant attorney generals that serve to give advice to each board. They have their own offices. They have their own budgets. And each board has its own licensing application process that they develop, and they each have their own licensing platform or software they use to issue licenses. As to the board members, they're appointed by the governor, most with the advice of the Secretary of Health. Board members are licensees, and each board has at least 2 consumer or public members. I think the Board of Morticians may have 5, but they all have at least 2 consumer members. Each of the members serve for a term of 4 years, and they're eligible to serve 2 consecutive terms. So you can see from this slide that there are approximately 400,000 licensees that are regulated by the health occupation boards in total. Among the 20 boards, there are 112 different licenses, certificates, and registrations that are issued. And 3 of the boards are general funded. The other 17 are funded by fees collected from licensing and other related fees. The boards set their own fees, and those fees are in their regulations. I wanted to point out that about half of the boards have online applications for initial application and accept electronic payments. That is, when someone's looking to apply for their license or certificate in the first instance, let's say to be a professional counselor. Professional counselors, for example, does not have online applications. It's all paper, and they only accept checks or money orders. That's one of the boards that does not have online applications and payments. About half of them do for initial application. But nearly all of them have online renewals. So each healthcare provider, the renewal term is usually 2 years. There are some that are shorter, but most are 2 years. And fortunately, all the boards have the ability to accept online renewals and electronic payment for those renewals. I think there are only 2 credentials under one board that is not able to process renewals that way. So to give you an idea of how the health occupation boards fit within the Maryland Department of Health, each board is considered a unit of the department. The Secretary of Health has authority over the boards to the extent that she is able to review and revise regulations proposed by the board, keep informed of the board's plans, proposals, and projects, and to require reporting. However, there are statutory limitations on the Secretary of Health's authority over the boards. The Secretary cannot disapprove or modify a decision regarding licensing, discipline, or investigations. The Secretary cannot transfer board staff. And the Secretary cannot transfer a function that pertains to licensing, discipline, or enforcement. In addition, I'd like to point out that the Secretary of Health is not, with the exception of the Board of Physicians, the Secretary of Health does not hire or manage the executive director of each board. The executive director is hired by the board and reports to the chair or the president of each board. The Board of Physicians is the only board that the executive director reports to the secretary. So I'm happy to take any questions, or we can move right along to the Board of Physicians.
Okay, why don't we, Senator Lamb, you can proceed. Yep, I'll let you go.
Thank you, Madam Chair. Just one quick question, I guess. There have been a growing number of licenses that are for some of the smaller health occupations that have fallen under, I think, the Board of Nursing, Board of Physician, and Counseling Board. And I'm curious to see if there's been any thought at the department about creating some sort of kind of allied health office to maybe take on some of these smaller professions and include them that way, rather than kind of jamming them onto existing boards where it's a little bit more ancillary to their mission.
Thank you, Senator Lamb. I'm not aware of any discussions in that regard, but I'd be happy to take that back to the Secretary for consideration.
Okay, thank you.
Thank you.
Thank you, Madam.
Thank you, Senator. Senator Reedy.
Thank you. Just a quick question about, I was noticing that about half the boards don't have the ability for online application at the initial phase. 2 questions. One is why, and second would be, could we get a list of which ones are not at this time? Later, I mean, I'm not asking you to read the
Yeah.
list You're sitting in front of us, but can you elaborate as to why that would?
Board is responsible for their own licensing processes and platforms, so it's really up to each individual board to organize, to come up with a way to process their applications, and just, I think certain boards have not pursued that yet for.
And, okay, and there's no way for the secretary or any secretary to say you shall or you must do this within the next year or the next, I saw what the secretary's responsibilities are, and the
Right.
secretary cannot overrule. It's probably for the best the secretary can't dictate investigations, things like that. We do want the boards to be independent that way, but the secretary has no real role in.
That's a question that's open for exploration. I think prior administrations have expressed an interest in having all of the boards be on one uniform platform for licensing.
But it has not happened.
That has not happened.
Okay. Thank you very much. I would like if we can get a list later.
Absolutely. I can
Thank
have
you.
that to you by
I'm
the
sure-
end of the day.
I'm assuming the committee members would be interested also, but thank you.
Absolutely.
Thank you, Madam Chair.
Thank you, Senator. We would. Senator Mounts.
Thank you, Chair. And so for the applications, is there a backlog right now?
It would depend on the board,
Do you-
which board you're talking about.
So there isn't like an analytical of the backlog of applications and things like that? I know I've had some pretty dire situations come up, and I didn't know what the status of processing those applications were.
Right, so the way it's set up at this point, you would have to reach out to each individual board to find out about, or I would, or the department would, each individual board to find out what the status of their applications are, because there is no one uniform platform to look at to see what, if there's a backlog of applications. So we would reach out to each board and ask them, do you have a backlog? What is that? There's no one unified system to find that out.
Is there a why? I mean, why is there a backlog?
If there is a backlog, again, there could be a number of reasons why. Sometimes, for some boards, it's June is a big graduation year, and so they get flooded with applications in June, for example. That could be a reason why. There are a lot of different reasons, and different boards would have to express, have to let us know what those reasons are.
But thank you, so your answer helped me out, to go to each board
Yes,
specifically.
yes,
Wonderful, thank you.
you're welcome.
Thank you. Any other questions for the committee? Okay, no, thank you. Your presentation was very helpful. I guess I was trying to get a sense of, I understand the things that you don't do because they're handled independently, and as the senator said, there's great reason for that. Is there a regularly scheduled check-in with the different heads of the boards, or, do you check in and say, let's take a look at your regs, or does it come up independently with each board?
It's a little of both, Senator Griffith. Secretary Schrader had quarterly meetings with the board chairs to
Okay.
discuss any issues and, what's going on with the department, what's going on with the boards. It was an opportunity to exchange that kind of information. When it comes to regulations, that's on an ad hoc basis, as not every board has regulations all the time that they want reviewed. So it's as they come up, they do go through the Office of Governmental Affairs, the Regulations Office within MDH, and they're addressed that way.
Thank you, thank you. And so there, I get it. It's not like on the calendar, every other month, this board is having a check-in. It's kind of working with each different executive director or, okay. And the other thing, you talked a little bit about the platform, and I know that in my other role in previous sessions, we talked a little bit about the shared IT for some of the boards. I understand some have unique needs. Is there any further conversation about that? Are we
So-
advancing that conversation at all?
The Department of Information Technology published a study that they, on how the boards could use the one-stop platform to create one platform, not a computer person, but that could, all the boards could use for their application system. So I'd be happy to get a copy of that report for you to share.
That'd be great, thank you. Any further questions? Okay, for Ms. Link. All right, we will go on to the rest of the panel. Please introduce yourself and you can proceed.
Good afternoon, Madam Chair, members of the committee. Thank you so much for having me. My name is Matt Dudzik. I am the Manager of Policy and Legislation at the Maryland Board of Physicians. I know I have brought a lot of info with me today, but I will make sure to keep things brief. The Board of Physicians is the regulatory body not just for physicians, but also for 13 other allied health professions. Maryland has had some form of formal licensure and discipline for physicians for more than 200 years. And, of course, a lot has changed over the years, but as Kim said, the most important goal is always public protection. And we handle that primarily through two arms, proactively through licensure and then reactively through discipline. So for a quick outline of the board structure, there are 22 board members. 14 of those board members are physicians. They represent a broad array of specialties, including emergency medicine, psychiatry, internal medicine, OBGYN, and more. We also have 5 consumer members that are sitting on the board, and then some other nominees as well. I've kind of outlined the structure there for you. One way that our board is structured a little bit differently from a lot of other boards is that we are broken into 2 separate 11-member disciplinary panels. This was done back in 2014 as a way to address a backlog in investigations and complaints. It allows us to more quickly process complaints, any pending issues. You can see here that all disciplinary matters are handled by one of the two disciplinary panels, rather than having to go before the full board. Just allows us a little bit of flexibility, more frequent meetings, because we don't have to bring on the full board every time we need to proceed to the next stage of an investigation or, close out a complaint or anything of that nature. The full board still handles kind of top-level issues, so there was a board meeting today. They handle policy and legislation. They appoint committee members, approve things like advanced duties and for physician assistants, et cetera. But again, anything that would involve disciplinary matters will go before one of the two panels. Our core duty is ultimately licensure. That is, the primary reason we exist as a board. We are the second largest health occupations board in Maryland. You can see that the bulk of that is made up by physicians. So we license over 50,000 providers, and roughly 35,000 of those providers are physicians. Other than physicians, we regulate a number of professions, including physician assistants, respiratory care practitioners, athletic trainers, and so on. We are also in the process of adding genetic counselors as a license category, with licenses to be issued beginning 2024. Our licenses are on biennial terms, so that's and we have fixed renewal periods for them. We attempt to stagger these renewal periods so that they're coming across, they're not happening all at once. Nothing is perfect. One sort of quirk of the renewal terms is that we actually have far more licenses that come up for renewal on odd years than on even years. So sometimes we get questions why, our revenue is always significantly higher in odd years. Why did you suddenly see a big drop in revenue? For example, in fiscal year 2022, we renewed 17,000 and change licenses. In fiscal year 21, we renewed roughly 29,000. It's just how it breaks down with the staggered terms. So we have not seen a reduction in the number of licenses. In fact, those figures have continued to rise. It's just the way our terms are staggered. You will always see a dip, specifically in renewals on even years. And as we add new professions, we try to add them to whatever year is lighter. One requirement for all licenses since 2016 is that we obtain criminal history record checks, or CHRCs. So these are basically criminal background checks that need to be sent to us directly from the Court Judiciary Information System and the federal government. It is worth noting that simply committing a crime is not in any way a bar to licensure. The board is specifically looking at crimes of moral turpitude or crimes that involve the practice of medicine. So in fiscal year 2022, we had 166 positive results, but none of those rose to the level of denying a license. It's, again, the majority of crimes would not be considered a bar to licensure. We also have a number of ways to expedite licenses. There are generally three reasons why we would want to expedite a license. The first is for our military. From the Veterans Full Employment Act of 2013, we automatically expedite the license of a service member, a veteran, or military spouses. Just immediately goes to the top of the list. There's an easy checkbox on the application where they can indicate that, and it automatically gets expedited. We also expedite licenses in cases of urgent public health requests. For example, if a hospital reaches out to us and tells us that, they need to get several people licensed in a hurry in order to properly meet staffing ratios, we would do everything we could to accommodate them. We saw this especially, we saw quite a few of these requests right around when Governor Hogan's emergency orders were expiring. And a lot of hospitals had relied on the provisions under those emergency orders to have licensees from who were licensed in other states. So they very rapidly had to become licensed in Maryland to continue providing that coverage. So we work directly with a lot of the hospitals to provide that. And those urgent requests sometimes come from hospitals directly, sometimes from associations like the Maryland Hospital Association, and of course from other state agencies. And then something new that we've recently implemented is licensure by endorsement. That actually just went live about 3 weeks ago. This is an expedited pathway for physicians who already have a license in good standing in another state, and this would essentially shift the burden of credentialing from the applicant. And credentialing is by far the most time-consuming part of the application process. There's quite a few credentials that need to be presented and verified. And this, for those who have already gone through that process in other states with the same requirements, we shift that burden from the applicant to the board. We confirm that with the other state that they have been licensed in, and we're able to process the license on a much faster time frame. As I said, we just rolled that in it went live about 3 weeks ago. We have had 21 completed applications already since, so hopefully more folks will continue availing themselves of that option as it goes on. And then, in order to support a robust healthcare workforce, we try to have as many pathways to licensure as possible. So we just talked about licensure by endorsement. We are also members of the Interstate Medical Licensure Compact, which has around, I want to say, 36 states are members right now. So you have the opportunity to apply through the compact to any of those member states. We've issued 900 licenses through the compact, and we've provided over 500 letters of qualification. In addition, there's something called the Uniform Application Process. That is something that was created by the Federation of State Medical Boards. It's basically a standardized digital application where a number of boards have agreed to use this standardized application so that you can apply with one application to any participating board. So right now there are 26 participating boards. We were actually part of the pilot program that first initiated this, and it's a good alternative for those who are working in multiple jurisdictions. And finally, it's not on this slide, but we are in the process of setting up a reciprocity arrangement with DC and Virginia. We were hoping to have that rolled in beginning of the year as well. Unfortunately, there were some delays. We were asked to delay it until February, so should be soon. The Maryland board is ready to go. Memorandum of Understanding has been approved by council. Our website's ready. We're just waiting on the other two jurisdictions. And then, even with non-expedited licenses, we do work very hard to get our licenses out as quickly as possible. Our goal is to issue 95% of licenses within 10 days of the completed application. And I'm happy to say that for the past several years, we've not just met that goal, but consistently exceeded it. I do apologize, we do not have figures for fiscal year 2022. The cybersecurity incident back at the end of 2021 has prevented us from gathering that data. We're hoping that we can eventually get it, but even throughout the cybersecurity breach, we have been consistently issuing licenses on our typical time frame. We were back up to our usual speed within that same week. So we are confident that we're still meeting those goals. I just don't have precise figures for that. And then finally, just a question we get a lot. So with all of these provisions, why are licenses sometimes delayed? And the most common reason is that the application is incomplete. An incomplete application sometimes means that the applicant has not filled something out, they haven't provided information that they need to, but a lot of times it can also mean an issue with the verifying entity. We require primary source verification for most of our credentials, which means that we need to have them sent to us directly from the entity that's providing the information. The applicant can't just send us a copy of their diploma or whatnot. We need to get that directly from the school. Another area where we see that it can sometimes delay things is with those same criminal history record checks we've discussed. It is a statutory requirement that we cannot issue a license until that criminal history record check is received, and so if there's a delay in receiving that from CJIS or the federal check, that can delay the process. And then, in some cases, something in the application process may have triggered an investigation, which could cause delays, but that's rare. I don't want to go into too much detail on the disciplinary process, just in the interest of time, but there are 3 stages to any investigation. So once a complaint is received, the first stage is a preliminary investigation. The reason why this is important is because no charges can ever be issued from a preliminary investigation. This is basically an investigation that determines whether or not a full investigation is warranted. So that when that preliminary investigation concludes, it's brought to one of those disciplinary panels. They will vote whether the complaint should be closed, whether we should issue an advisory letter, which is a non-public, non-disciplinary letter, just advising, saying, what you did was not a violation of the Maryland Medical Practice Act, but there are some ways this could have been done better, or direct a full investigation. That full investigation, once that concludes, goes back to the disciplinary panel, and then, if necessary, we'll proceed to charging. In general, we try to resolve things through a dispute resolution conference where we will resolve things with the licensee through consent order. When that is not possible, it, of course, will be forwarded to the prosecutors at the Office of the Attorney General, and then the case goes before the Office of Administrative Hearings. As far as where complaints come from, they can come from quite a number of places. By far, the most common source of a complaint comes from either the patient themselves or from a family member. So in fiscal year 2022, we received 752 complaints. 444 of them came from the patient or family member. Sometimes when there's a complaint, it'll say board referral. That is generally what I discussed before with when an application triggers an investigation. So something on the application has caused us to investigate, whether it's a discrepancy between what's on the application and the verifying documents, or something in the character and fitness questions that requires us to investigate. That accounts for roughly 13% of our complaints. And then as far as what the complaints tend to allege, almost 80% of the complaints allege either unprofessional conduct or failure to meet appropriate standard of care. Those make up the bulk of our complaints. And then after that, the next highest category is failure to keep adequate medical records. So issues with receiving your medical records, getting them transferred to the correct facility, et cetera. And that constitutes about 7% of the complaints we receive. And then I do want to just go into standard of care a little bit, because the Maryland Medical Practice Act does not determine standard of care. Standard of care, and that's intentional, standard of care is constantly evolving and changing over time. So when an allegation that a practitioner has failed to meet standard of care comes up, it goes to independent peer reviewers. We send it to 2 independent peer reviewers, and they have to agree that standard of care was not met for the case to proceed to any potential charges or anything of that nature. So that's generally how these cases come up, and it's not solely being determined either by the Medical Practice Act or by the board members themselves. We do have this independent peer review process. Again, just in the interest of time, these are just some statistics about disciplinary actions we've taken. Of course, I'm happy to answer any questions you have about them, but just I know we have quite a few folks here, so just to kind of move on beyond that, we also have mandated reporting requirements. These are requirements that hospitals and other facilities have to report certain changes to practitioners, to our board. So for instance, if somebody working in a hospital had was terminated or had a restriction of their privileges, those facilities are required to report that to us within 10 days. Not every change is reportable. So for instance, maternity leave or military deployment, they don't have to report that, even if that meant that somebody has stopped working for those reasons. But if, essentially, if any time a practitioner has done something that might constitute a violation of the Medical Practice Act, we need to know about it. We need to know if this needs to go to an investigation on our end. And then finally, we've been working hard to improve our website, make sure that just to improve transparency for anybody that is looking for information. You can find things like disciplinary alerts. Any disciplinary action that we take is published on our website. We also have rosters. These are updated monthly. These are rosters of individuals both licensed by us and those who are inactive. Some other information is there as well. And then we also have a very robust practitioner profile that gives not only the license information, but also information such as whether or not that practitioner accepts Medicaid, where they received their training, whether they are licensed in other states, and if they have any disciplinary action in those states. This is all information that you would find on our practitioner profile. It's right on the front page of our website, there's a big blue button that lets you access it. So we've actually received some kudos from some national groups regarding how much information we have there. And we just want to make sure that Marylanders are able to make an informed decision about their healthcare providers. We include both active physicians, so I mentioned we have over 35,000 of those, but also just because your license expires, we still have that information up there. So there are over 120,000 licensee profiles available currently. And then finally, as far as data sharing, we receive data from a variety of sources that's published online. We also have some agencies that we share data with. I've identified a few right here. I think that about covers it. Of course, we are happy to answer any questions, and thank you again for giving us the time to introduce ourselves.
Thank you very much. I have Senator Lamb and Senator Ellis.
All right, thank you, Madam Chair. Mr. Dudzik, good to see you again. Thank you for the presentation, very comprehensive. I wanted to touch on you mentioned the Interstate Medical License Compact earlier, and very concerned about how other states are addressing abortion care. And because these compacts are binding in some ways to Maryland, I'm concerned about how a lot of these compacts could potentially impact our practitioners, particularly if there are other actions taken by other states when it comes to their abortion care laws. And so I'm curious to see if the board has started looking into this, what some of the thoughts of where the direction of the board might want to go when it comes to abortion care, because my concern is if there are folks that are licensed in other states that are compacts with Maryland, that if they begin an investigation in another state of that provider, that could trigger, I think, some action here as well, and potentially an investigation of the provider here because they're licensed and there's this bi-directional linkage through this compact. It gives me pause to any subsequent compacts at this point moving forward because of the abortion care issue. But I wanted to see what the Board of Physicians is thinking about with this.
Sure. And thank you for that question. There are grounds within both the Medical Practice Act and the Compact that state that when we take reciprocal action, we would only take that action if it would be a violation here in Maryland. You do raise an important point, though, because one aspect of the Compact specifically states that if the state of initial licensure for a compact state suspends or revokes a license. So it's only if it rises to suspending or revoking a license, not just an investigation. But if they suspend or revoke a license, all other member states must automatically suspend that license. And it's to be for up to 90 days in order to give those states, I think it was intended to be an emergency provision to make sure that, if something was serious enough to warrant suspension, that it would be suspended across the board and wouldn't be able to continue practicing in other states. We have had counsel look at that because it is a shall, not a may, so we would be required, if that happened, to follow through with that suspension. Again, because we have specific provisions that state that we would not have to take action if something would not be a violation of the Maryland Medical Practice Act. We would, of course, be able to ideally remove that suspension in as timely a manner as possible. But it is a concern. One of the reasons why we would like to have multiple pathways to licensure, though, is to minimize some of that impact, because this only applies to those that are licensed through the compact. We have been, and the compact has been absolutely fantastic for getting people licensed from a number of jurisdictions or a number of states. But one way that we hope to minimize any impact of interstate issues like that is by making sure there are a wide variety of options for licensees from out of state to become licensed other than just the compact.
So if a licensee was first licensed somewhere else and the provider was suspended in that other state, then potentially we may have to suspend them, but we have provisions in our law that would preclude us from having to do that.
Correct. So the provisions in our law wouldn't preclude us from that initial suspension, but they would preclude us from taking disciplinary action if it would not be a violation in this state. And that suspension is intended to give the individual boards the opportunity to investigate and conclude whether it would be worthy of disciplinary action. So, we would try to minimize the time. If it is something that is not an issue in Maryland, we would try to, of course, minimize the time that suspension remains active. It's also worth noting that it is when the suspension is lifted, it is done, with prejudice. It does not remain on their record at all. We do not. It would be entirely removed from the. It wouldn't show up as prior disciplinary action or anything of that nature.
Okay, well, that's helpful.
Yeah.
That's helpful context, so I appreciate that. I think it does give me pause with any subsequent compacts that this committee or the legislature will look at, particularly as we try to sort out the Dobbs decision. Thank you, Madam Chair.
Thank you, Senator. Senator Ellis.
Thank you, Madam Chair. Thank you for your testimony, for your briefing. So I'm just going back to the hack and the disruptions that happened a few years ago. Are you seeing any after effects from that period of disruption? And I know we put in some bills last year, became law, cybersecurity and improvements. How is your agency, your board, and kind of fixing whatever weaknesses might be there? Whatever you can share with us publicly.
Certainly. Thank you for that question. I believe our board was luckier than most. We had already converted to an online licensing system, and we have our own internal IT department and our own IT director, which is a luxury that is not afforded to, or that not every board has, unfortunately. We were able to return to operations very quickly. We had folks come in right away within 48 hours. We were back to our usual time frame for issuing licenses. But I do know that that is what is true for our board may not be true for others. We, as I said, are very fortunate, and it is. I'd love to say that it was great foresight that brought us there, but I think some degree of it was just chance. That being said, we are certainly still feeling the overall effects of that. I mean, while we are issuing our licenses on the typical time frame, we had to create provisions and workarounds to do so, and we're still not back up to functionality. We're still not reconnected to our typical network. We're just in the process of kind of getting back up to speed. I think it's just in the past couple of weeks have we started to convert back to using our main computers rather than working off of these temporary laptops and iPads that have been kind of our solution hitherto. But we have a lot of staff. We make it work. The priority is getting the licenses out in time, and we do everything we can to do so.
Okay. So did you experience a lot of backlog from the board back then, or folks waiting? Did that affect the board, or just other?
Thankfully, we largely did not, and a lot of the reason for that was because of the way our online licensing system works. Because those license applications were coming through as an online system, we still retained access to them. We didn't lose access to any pending applications when the cybersecurity incident occurred.
Great, thanks. Yeah, moving on to another part of your briefing, physicians' complaints and what is public? What is made public? Is it identifiable to the individual, or is it scrubbed and it's basically general information out there?
The complaint itself is never made public. If the investigation rises to disciplinary action, then that discipline is public. And that, so if there is an order, the order may say that the board received a complaint alleging that, such and such scenario occurred. But the actual complaint is never made public, and in the orders, we de-identify, so we would refer it to patient A, patient B, hospital A, hospital B, et cetera. We remove that information. We do also accept anonymous complaints. We investigate everything. Again, we have that preliminary investigative period to determine whether there is merit to the complaint, and we try to take it very seriously.
So if there is no merit to a complaint, nothing appears on public record. But
Correct.
if there is a merit to a complaint, you find that there is some fault, so that finding, and any disciplinary action is put up on the website for folks to see? And how long does that stay there?
So we are required to keep it up for 10 years. We don't currently take it down. We do have regulations that are pending, that they've been submitted downtown, that would allow us to, that would allow physicians to apply for expungement of certain actions, but it's very limited, specific to things like failure to obtain CME credits in timely fashion, or...
CME, what's that?
Oh, I apologize. Continuing medical education credits. So if
Yeah,
if
for
they...
us CPS, it's CPE, so it's good to.
Yeah, it's, I'm
I
so
thought
used...
that's where you were leading, but. just wanted to clear.
Understood,
Yeah.
Senator. It's, I default to a lot of the terminology, and I apologize. But
So you're saying the rule, the law says it should come down after 10 years, but you just don't take it down? It just stays up 11, 12,
Well,
15 years?
the rule of law says that it must, so the provisions say that it must be up for at least 10 years. So we, it does not say that it is to come down after 10 years.
Yeah, so you just leave it there forever, in perpetuity.
Correct, in general case, unless we have a reason to bring it down,
So
correct.
it's totally subjective.
I believe it's, I can certainly look into that, but I believe it's across the board.
Approve it. And one last question on the veterans, military members coming into Maryland. So they go through the expedited process? And how long does it take usually for someone coming into, military spouse, military member, coming into Maryland to get their license?
It depends on if they have all of their documents prepared. I mean, typically under 48 hours. Once we have that completed application, of course, there are some aspects that can take more time. So, for instance, the criminal history record check, if you're in Maryland, you can go to any number of facilities, get fingerprinted, they send it right away. If you're out of state, the Court Judiciary Information System requires that you send them in a fingerprint card. That process can take more time. We always encourage, if you know that you're moving, to deal with that in advance, because again, it's the law states that we can't issue the license without that step.
So do you think that process is fast enough and going efficient enough, or there could be some changes to make it more efficient?
We are very confident that, we issue our licenses as quickly as possible, and especially in cases where there is expedited service. We also, when we expedite a license, we actually have licensure staff that is specifically assigned to kind of walk that through, handle any issues that we run into. Again, there's always a balance because, of course, we must verify credentials, and we must make sure that anybody that's working here has met the qualifications to do so. Because especially with some of the allied health fields, those requirements and educational and training standards are not the same from state to state. And we do need to make sure that they meet those standards here in Maryland, but we do everything we can to get that out as quickly as possible.
Thank you, sir. Thank you, Madam Chair.
Thank you, Senator. Thank you. I don't see any other questions for this witness, so we can proceed with the panel. Good afternoon.
Good afternoon. Thank you, Madam Chair and committee members, for having the Board of Nursing here for this briefing. Okay, just wanted to do a brief introduction to the board. The Maryland Board, I'm sorry? How's this? Okay, thank you. The Maryland Board of Nursing is the largest health occupational board in the state of Maryland. We have approximately 281,000 active practitioners. That doesn't include our inactive, which is over 400,000. The board is mandated to regulate 16 designations. So to Senator Lamb's point, we have a lot of allied health under the Board of Nursing. There are three additional distinctions between the Board of Nursing and other health boards. The first is that the statute requires that the executive director be an RN. The next is that our nurse investigators, they are different from the other boards. They have to research practice of standards, investigate complaints. They do a review of investigation. It's very long, similar to the physicians' process. We are very similar to that, so I don't want to bore you with that. The board also approves education and training programs for multiple designations. So, of course, we do the generic RN program. We also do advanced practice programs, certified nursing assistants, dialysis techs, medication techs. So we approve all of those as well. Okay. So as far as the Board of Nursing operation, we have a variety of operational units, and we work collaboratively in order to meet our mission, vision, and values. So we have 12 operational units, and we have 14 committees. Our operational units, of course, is administration, background review, compliance. I'm not going to read the rest to you, but the rest are there for you. And we have a variety of committees. A couple of committees I just want to point out. One is the Criminal History Records Check Committee. In the last 4 years, what the board has developed is also what's called a matrix. And what that matrix, I am allowed to approve individuals as long as they fit on the matrix, which helps speed up someone being licensed, instead of waiting for the board to actually approve. So the board usually approves the felonies in this case. And I think over fiscal year '22, there was only one person that was denied licensure. The other committee I would like to point out is our Safe Practice Committee. This is a committee for those who have drug issues, alcohol issues, drug diversion. What we do with those individuals, if they self-report, we bring them in, we work with them for 5 years. They have to get drug screening, they have to follow certain rules, they only can work on certain shifts. And so we really work with them to help rehabilitate them so that they can stay employed. If they do not complete the program for not maintaining the requirements of that program, then they will go into investigation. So that's one way if someone self-reports. The other is we have individuals that the facilities report to us. If they meet the qualifications for safe practice, we try to go that route first so that we can assist them. So those are the two areas. So we have had recent reports and publications, the Joint Chairman's Report of 2021, which also referenced older studies, which was the Sunset Review in 2010, as well as 2013 for a legislative report. We've also submitted 3 Joint Chairman's Report and 2 annual reports in fiscal year 2022. All of these reports can be found on our website. And in 2022, the Department of Legislative Services submitted a report detailing the board staffing, internal organization, funding, licensing, and complaint activities. This report was more detailed, historical, problems faced by the board, which has definitely been documented since fiscal year 2021. The report additionally outlines new information that has not been published in previous reports. So obstacles that are faced by the board. In fiscal year 2021 and 2022, the reports reintroduce operational and informational technology staffing challenges that have existed since 2010. And the following obstacles have persisted over time, spanning multiple executive administrations. There's no informational technology resources that can track incoming calls or emails. The board continues to operate with 2 antiquated licensing systems, which is over 20 years of our 2 systems. And those 2 systems do not interface with one another. So the IT team has to manually move the data from our online system into our internal database. And the existing fee structure cannot adequately support our operations and fiscal responsibilities. We have not been allowed to increase our fees regulatory-wise since 2008. Yes. Just to give you a for instance, as far as staffing and human resources are concerned, the board has a total of 91 positions. Currently, only 59 are filled at the time, which means we have 30, well, currently, because we've just hired 5 new individuals since we wrote this, has 33 openings right now. And if you can see through our number of licensure personnel is 7. We have 1 vacant position that we just hired someone in. And so for each, and we have 281,000 constituents, which means for each person it's 46,000 that one person has to touch on. So all of our operational units have been severely affected by the staffing shortages. However, the most important units that really affects our stakeholders and constituents are licensure, certification, and complaints and investigations. Licensure, the one good thing we have in licensure is that when someone endorses into the state, they can apply for a temporary license at the same time, and they can just start working at that particular time. As we look through their application to make sure it's complete and their background check is okay. Sorry, I forgot what I was going to say. The certification team is the same for the allied health piece. They also can receive a 90-day letter that can have them start to work right away as well. And for our complaints and investigations, Rhonda, do you want to speak about?
We can come back.
We can come back to it? Okay. Oh, there we go.
Okay, good afternoon, Madam Chair and members of the committee. Thank you for this opportunity. So right now, our Complaints and Investigations Department is, Rhonda Scott, Deputy Director for the Maryland Board of Nursing. Apologies. The Investigations Department is staffed by 3 experienced nurse investigators, 1 experienced non-nurse investigator, and 1 non-nurse investigator in training. So we currently have a total of 5 investigators, and 4 of them are experienced. The director and manager of the enforcement division are included as experienced investigators, so they are actively participating in investigations and are actively assigned. As you see, the director herself has at least 600 cases, whereas the manager about 500. We have, struggled historically to fill and retain investigators for these positions. One of the things that we had identified was that the position itself was not appropriately classified, and when it was posted as a health facility nurse surveyor, many of the investigator applicants thought, well, they would be going out particularly to possibly just look at facilities and investigate facilities and as a state surveyor, survey facility operations and things like that. However, in actuality, particularly our nurse investigators, they are charged with coming in and, conducting in-depth research into standards of practice, best practices. And I'll give you for instance, if we have a case alleging violations of the Practice Act against, let's say, a nurse midwife or even a non-nurse midwife, and if it's taken to, forwarded to investigations, that nurse investigator assigned is going to be researching best practices, standards of practices for that particular person's specialty area. It takes a lot of time to do this in-depth research. They're subpoenaing all the evidence and information that they can get, and sometimes that takes time and is, often can cause delays. They are reviewing these documents. Sometimes, depending on the severity and the complexity of the case, they are subpoenaing and waiting for particular cases that result in death of a patient, they're waiting for medical examiner reports, they're subpoenaing records from Vital Records Administration. So their work is very in-depth. And what has happened historically when we hire folks for these positions is they can't really meet the, or keep up with the pace and the expectations of the role in submitting their cases, because then once they have interviewed witnesses and collected all the information, they're now required to write an in-depth report of investigation to take to the committee to review, to determine, if these allegations, what type of, look at charges and things like that, and then forward to prosecutors and things. So it's a pretty robust process that a lot of the incumbents that we have had in the past have struggled to be able to effectively, master, resulting in folks leaving or just not meeting productivity requirements. So, right now, our investigative team they're currently assisting a federal agency with a current case that has national implications across many states, including Maryland. And as a matter of fact, this agency is utilizing the investigative information that our nurse investigators have collected to assist with their investigation. Our investigators have also partnered and assisted the OCSA, Office of Controlled Substance Administration, investigating prescriptive practices of advanced practice nurses. So they are, they extremely, busy constantly. It's nonstop for them. And as you can see by the amount of investigators we have, they are very challenged with getting investigations completed timely because they don't sacrifice accuracy and efficiency just because they are so, overworked and overwhelmed. They are still putting their all into these investigations, and it's very critical. And it's difficult to see them on a daily basis working as hard as they do and still coming every day, very encouraged to get the job done. So one of the things that we have looked at is that what we would possibly need to improve our, ability to investigate more timely is approximately 20 additional investigators and 4 administrative employees to assist with, issuing subpoenas and letters, sending out contact letters to respondents, letting them know that there's a complaint against them, and trying to schedule interviews and things like that would be very helpful. Just wanted to kind of put some context behind why you see the number of cases that are assigned. We currently have a large backlog of over 3,000 cases that have date back from 2018 and older. And currently there's about 2,600 cases that are currently active. And there are some cases that we haven't even been able to assign just because of the sheer volume of cases in relation to the number of staff that we have to be able to investigate these cases. So it's as you can imagine, is extremely difficult for this team.
Thank you. So as far as the funding source for the Board of Nursing, we have the second lowest funding balance of all of the health occupational boards, as you see there, $906 and change. Health Occupational's Article 8-206 restricts the board from receiving aid from other state or federal funding sources, such as grants. So one of the items that we would like to do this year is to see if we can remove that so we can apply for grants to help us out with funding the board. And additionally, the board has, I explained that to you, as far as our funding, not being able to raise our fees since 2008. And again, that was regulatory-wise for that. As far as informational technology resources, again, we utilize 2 resources. We have the LARS IT system, which is our online licensing system for both our licensing and certification. And then we have our Milo system, which is our everyday database that we work with. that we put all of our information, including investigations, that's our main system to work on. However, as I stated before, they are over 20 years old. And these systems need to be upgraded. I've been with the board for 5 years. I've attempted several times to procure a new and up-to-date technology system, and it has not come to fruition. It's been stopped. So the Department of Informational Technology, the Board of Nursing, June of 2019, started working with the Department of Informational Technology with the one-stop licensing system, and that was over a period of about 2.5 years. COVID came in between, so sort of stopped for a little bit. However, the cost of that would be over $5 million, which is almost how much we make a year. And then our current phone system cannot accommodate the amount of calls that we receive daily. Sometimes there's times we can't even call each other in-house. And when we call out to speak with a constituent, sometimes we're blocked from even calling there. And there's times that they can't call us, or it seems like they're being put on hold forever. But we added more and more, I forgot what those things, trunks, thank you, more lines so that we can stop that from happening. But I guess we have to order some more. Some solutions that we have come up with. One is the long process for getting someone hired. So one of the solutions that we would like to do is to have the 5 top boards and the representative from the smaller boards to work with DBM and HR to see what we can do to streamline this particular process. The other is to work with the procurement office, again, with that same group, to see what we can do to streamline that as well. Also pursue a new licensing system. In 2019, I had asked for the Board of Nursing to upgrade the Milo system. If we were able to do that, one, we would be in the cloud, which would have been great during the ransomware time, and also through COVID. We were unable to get that approval. Oh, also what we wanted to do is, instead of having the 2 databases, we wanted to have just one database, and that would have been great. So that was stopped. So what we would like to do this year is to be able to get a new licensing system and put all of our licensing on one system and everybody online. The majority of our applications are online for initial renewal, et cetera. However, for every new person that comes in, like for our, what do we have, licensed certified midwives, dialysis tech, direct entry midwives, and electrologists, they're still on paper. So National Council of State Boards of Nursing has a system called ORBS. And for ORBS would be great if we're getting it. 12 other boards throughout the country has ORBS. They keep on telling me how wonderful it is, and I believe it with some of the things that ORBS can do. It is a free system to the Board of Nursing. And that means they are going to customize it to what our needs are. Additionally, there is no fee, no maintenance fee, nothing. So the only effect as far as payment that will hit is when we're moving the 2 other systems onto this one platform. And we would just need to pay Lars and Milo for that. The great thing about this new system is that normally we have to wait for an initial license. We have to wait 48 to 72 hours to obtain it, even though the license holder usually knows that day. With this ORBS, it will automatically drop into our system. We will know at the same time. Additionally, and one of my favorite pieces, is that an applicant can find out what is missing from their application, so it will automatically tell them. And they'll be able to have access to look up what's going on in the system. I think it's a wonderful system. I just look at my fellow executive directors across the nation, and I can admit I'm a little jealous, but I would love, and I say that because I know what we're working with now, and I'm sorry, I'm a little passionate. I just want what's best for our constituents, and I know we can get there. We just need the resources and we need the equipment in order to do that. The other thing that I've built up that the board did not have before is customer service is ultimate to me. And when I took over this role, I wanted to change the Board of Nursing look. Unfortunately, we're still there because we don't have resources or an IT system. However, I've built up with the community as far as the deans and directors. I meet with them frequently. I meet with the Maryland Hospital Association every other week. I meet with the chief nursing officers across the state. I meet with HR across the state. I'm missing the community colleges when it comes to the Certified Nursing Assistant program. So I'm sure there's a couple of more. I can't think of it right now, but I built this up because I wanted to hear straight from our community what their concerns are with the Board of Nursing. And we have been working on a lot of solutions. So we've been working it out together slowly, but we've been working it out. And I just love that relationship that has been built up. The last thing, as far as legislation we would like to see, is competitive salaries. And a job classification that actually matches what the job is. So definitely for the health surveyors, when we even put one in for a reclass, Rhonda, do you want to tell them what happened with the reclass? That they didn't understand what our role.
So, and actually, I did neglect to mention that with the health facility nurse surveyor classification, our Director of Enforcement worked very closely with one of the Department of Budget Management personnel to help to identify specifically and properly classify the duties of the nurse investigators. So it was finally reclassed after much effort and back and forth between them and having an understanding of how in-depth the role of the investigators are. They reclassed it to a nurse program consultant administrator, which is more in line with what they're doing. The pay is more competitive now. So we're getting more applicants, which is great. We only have a couple positions that are open, which means we're not allotted that many vacant. We don't have that many vacant positions to fill the need, but we do have a few that we're actively recruiting for. And we're hopeful that with the reclassification and the, more specific duties outlined there, that we're going to get more folks that are qualified to help with these investigations.
Yes. Thank you, Rhonda. So, are there any questions?
Well, first, let me thank you both for the presentation and the valuable information. I can tell you, many of us have heard concerns from constituents, but really didn't have this foundation and this background information to view this issue from your lens or the issues that you're facing. I just have one quick question, and then I know we want to hear from some members. You referred to, in your solutions page, you had questions about amending the health occupations article to remove the restrictions on your being able to get funding and allowing your executive leadership to do independent salary setting. I'm assuming that's what you're asking for. Do you have legislation proposed this session to address these?
Not yet.
Okay.
Not for that one, no.
Okay, for the budget, have you put any funding budget request, or you have to change the language before you can ask for?
We have to change the language.
Fair enough, fair enough. Okay, I'm going to go Senator Ellis, then Senator Lamb this time.
Thank you, Madam Chair, and thank you, ladies, for your testimony. And I must say, I really appreciate all that you do as nurses and for nurses. My late mom was a nurse, and I understand from her experience a lot of the issues that nurses go through. And so I just want to kind of ask several questions. And I ticked off one, the chair asked that one. So, so moving forward, you are also responsible, Board of Nursing, for entry-level midwives. Is that how you say it?
Direct entry.
Direct entry midwives, right. And so if you could explain what they are. And I have a specific question, if, on your opinion, if direct entry midwives, if you think they're capable, experienced enough to treat ladies who have had or will have a vaginal birth after cesarean. Could you share that with us, please?
Thank you for that question. It's a tough question.
Yes, it is.
It is. The majority of the time, they do vaginal only.
Well, could you tell us what a direct entry midwife is first, and then? get to
Sure.
midwife?
A direct entry midwife is a midwife that has a different type of schooling. So they're not licensed nurses. They haven't gone to a college, such as the licensed certified midwives do. So it is that a good description?
Yeah, I think the main difference is that they're not nurses, but they have the training as far as the midwifery piece of it is concerned in their education.
And they are
the-
licensed.
Yes,
Through
they're
the
licensed.
Board of Nursing.
Correct, yes.
Yes.
Okay, go ahead, thank you.
Yeah, since 2015 or 16,
Okay.
they've been licensed. Prior to that, they were not.
Okay, thank you. So your opinion now on the second half. I'm not going to let you off that easy.
I really would have to, I don't have the information. Like, I would need some further investigation of that. I'd be happy to get it back to you.
Okay, so knowing what they do currently, and I know some members in that professional class are attempting to expand their scope to do vaginal birth after cesarean.
Yes,
And that's a very big ask,
yes.
you know, so we would love to have the experts weigh in on that eventually, right?
I mean,
Not to pressure you now, but you can reach out to me later, reach out to the committee later.
yeah,
if you
I
so
was going to
choose.
say that neither of us are really experts as direct entry midwives. We have a direct entry midwife advisory committee who, yes, they are the experts, and I'm sure they would answer yes to that question, but we're not really. And I know I wouldn't be comfortable really, opining on whether or not they're experienced enough based on what their training is. I know there was some discussion. They convened a group last session when they had the legislation introduced, but yeah, at this point, we don't.
We can share that document with you, though.
Okay, if you can, please,
Yes.
with myself and the committee and stuff.
Be happy to.
Okay, thank you very much.
You're welcome.
Thank you, Senator. Senator Lamb and then Senator Guile.
Thank you, Madam Chair, and thank you. Good to see you again, Ms.
Yes.
Evans, Ms. Scott. So a lot of good information. I think it's certainly, even coming over from the Education, Health, and Environmental Affairs Committee, where we dealt with health occupations, this overview has been really important to kind of give a sense of scope of the challenges that the Board of Nursing is really facing. And I think I can tell from your passion with the mission that the board has, that you in many ways feel like there's a large number of challenges and a crisis facing the board. And I think the overview certainly helps with our understanding that. I am very concerned, given all the challenges that you laid out there, and I want to touch on some of them just to be able to get a better sense of why those lie there. But when it comes to you cite the fact that the board has not been permitted to raise fees to cover costs.
Yes.
Can you articulate who has declined to permit you to raise fees?
So there was a memo that was put out in 2016 by Governor Hogan that we are not supposed to increase our fees. However, I still asked, and then it was blocked by the Secretary's office.
How many times was it blocked?
I only went one time about 2 years ago.
And was it Secretary Schrader?
Yes.
I see. You cite the fact that you've also tried to seek a new IT system, and it sounds like that was also blocked or declined from proceeding.
Yes.
Can you articulate why that was blocked from proceeding and who blocked that?
It was the Secretary's office who blocked it, and the rationale is because of the one-stop. And that's one of the reasons why I said, well, let's work with the one-stop so we can upgrade our system. And then it came out to $5 million, which we definitely cannot afford. So every time we went through procurement, it was halted.
Okay. So it sounds like a lot of this is routed through the department, and the department on multiple occasions has declined to either provide resources, support, IT approval, or the addition to be able to increase fees to be able to self-sustain the board.
Yes, and if you don't mind, Senator Lamb, during the summer of 2021, the Secretary did provide us with 28 temporary employees, and we were caught up with everything. And then those employees were pulled, and then the ransomware happened. So that really backed us up, and we're still working on, the majority of everyone, especially if they're online, are able to license with no problem. But we want to be better than that. I want us to be able to license no later than 3 days. It shouldn't take that long to license the individuals, but we're just stuck with what we have, and we're trying to do the best with the resources that we have.
But the additional help you got from the former secretary, to be clear, were temporary employees, right?
Yes.
And so when they are no longer with you, obviously, and you cite the fact that you currently only have 59 positions filled of the 91 that you have.
Correct.
And is that because you don't have the pins, or you don't have the funding, or you're not able to retain or keep people because of the salary structure that you're limited by?
Well, a little bit of each. So as far as keeping staff, a lot of our key staff members who have left over the past year, one was not being able to do hybrid, and the most important one was fees. So salary, excuse me. They all left because of salary. A lot of them left because of salary. I think they would have stayed even if we weren't hybrid. The second is we don't have enough funding, since we haven't raised our fees, to cover staffing. And then the third was, I think there are not too many merit pins that are left. So the majority of those are contractual, and it's very difficult to keep contractual employees because it's not a merit pin.
Okay. Can I ask Ms. Link to respond as the representative for the department, also for the secretary? It sounds like there seems to be and has been some impediments in the history of this, discourse to be able to support the board to the adequate needs that it has.
Sure, and I know that former Secretary Schrader worked very closely, and his team worked very closely with the board, especially during COVID, and was the one who insisted that the board accept the 28 staff to help for that temporary assistance in order to get them up to speed, with the backlog of applications. And I think it's important to note that some of the issues of the Board of Nursing go back a very long time, before Ms. Evans joined the board, and certainly COVID didn't help. In terms of the IT system, it is accurate to say that the Secretary encouraged the board to join the one-stop system through DO-IT, and the board was working with DO-IT before COVID came. DO-IT did put out the...
How are they supposed to do that when there was a $5 million bill attached to the what Maryland
Well,
systems?
last year, Senator Lamb, Secretary Schrader offered to cover all of the IT administrative costs for all of the boards, including the Board of Nursing. He said that he would take on, the department would take on all back-of-the-house costs, including IT. So those discussions are still open. Now we have a new administration. We can hopefully move forward. And in a perfect world, we have all the boards on the same platform so that we're able to access all the data, and especially that would help with the workforce issues that we're currently facing.
Would having all of the boards on the same platform put us even at greater risk if there were a cyberware attack that attacked that platform? It would take down all of the boards at the same time.
It would be, as I understand it, the one-stop system is managed through DoIT, and with the new cybersecurity initiatives that the state is undergoing, it would be cloud-based and presumably under the protection that all other state agencies get through DoIT.
Okay. I'm not sure I have that degree of confidence in the
Understood.
the state system. But I guess and this may be for you or the board, you know, it sounds as though there's been a little bit of tension there to be able to get the resources for the board that it really needs. And I think with a new secretary coming in, looking at this, I feel like the board's being put in a tough position where they're being asked to do things, but they're also requesting resources and they're not being provided the resources to be able to do what the department has expected or the governor is asking them to do. And so they're stuck in this situation where they're unable to really fulfill some of their requirements, but not being able to provide have the resources to be able to do so. And so this may not be the exact circumstance with the Board of Nursing, but maybe more so with the Board of Physicians. When boards have the PINs to be able to hire new employees, but are there instances where they're not able to, not permitted by the department to fill those PINs even though they have the PINs?
I cannot attest to one instance where the department has said you're unable to fill a PIN that a board already has. I note that, I believe Ms. Evans said they have 33 openings currently. Those are for PINs. So it's more than providing more PINs. It is a matter of recruitment and retention, which the Board of Nursing has had trouble with over time.
Have there been boards that have had to fight for PINs even when they have the money?
I'm
So for example,
certainly-
the Board of Physicians has funding. Do boards like that have to fight for PINs even when they have the funding?
So as far as PINs go, they're in the Department of Budget and Management. The Department of Health has allocated a certain number of PINs from the Department of Budget and Management. So the Department of Health has its own quantity of PINs that it has to give out. I've recently asked boards to let me know their requests for more PINs. Other than the Board of Nursing, I haven't received any requests from any of the other boards that they would like new PINs. Some would like contractual PINs converted to merit PINs, which is an ongoing discussion. I think every board would like to have more staff, but in terms of formal requests, and other than those contractual conversions, I have not received any.
How many more PINs has the Board of Nursing requested?
I don't know off the top of my head.
Okay. All right, well, thank you, Ms. Link, and thank you, Ms. Evans and Ms. Scott. I know it sounds like it's been a real struggle and a real challenging period over the last couple of years, and I appreciate the work that you and your staff do in the Board of Nursing.
Thank you, Senator Lamb.
Thank you, Senator Guile.
Thank you, Madam Chair, and thank you, Ms. Evans and Ms. Scott. Your passion and your commitment to your job, despite the very frustrating challenges you are experiencing, are evident, so thank you. I do have a question regarding the complaint backlog.
Sure.
And obviously, it's really concerning. And it's, you discussed the reasons why. I'm not suggesting that there's any blame accorded to you based on what you were just discussing. But I do want to ask, is there some prioritization given to the complaints that are received based on severity?
Absolutely.
Okay,
So
can you
we-
speak a bit on that,
Sure,
please?
do you want to?
Sure.
Okay.
So what the board, we model after the National Council for State Boards of Nursing priority level when they're assigning cases. So priority one are cases that are assigned to cases that involve either death of a patient or where severe harm has been caused and that the person is potentially an ongoing threat to the public and public safety. And then you have priority 2, 3, and 4, which are a little lesser degree. So typically, right now, our investigators are, of course, focusing more on the priority 1s. That's, what's currently being investigated right now with what we have are all priority 1 cases, just for, because of that.
And so I assume they don't have the capacity or bandwidth to really get to Category 2 or Category 3 level complaints?
Not like we would like to. no.
Okay. What kind of complaints would rise to a Category 2 complaint?
It could be a medication error complaint that didn't result in harm. Potentially mostly practice issues that don't result in any type of harm, but has a potential for harm the patient.
Okay, a potential error that if repeated
Correct.
could
Yes.
potentially cause harm in the future,
Yes.
correct? Okay. Those are all the questions I have. Thank you so much for your time. Appreciate it.
So, excuse me, Senator Gao, would you like us to send you the National Council of State Boards of Nursing guideline?
That would be helpful.
We'll be happy
Yeah.
to send that to you.
And we
Thank
can
you.
also include more specifics as to what type of cases fall under what category, if that would be helpful as well.
Thank you. And I'm sorry, I do have one quick question. You talked about the inability to raise the current fees. Could you just tell me what the current fees are?
So I'll keep, for nurses.
Is it a complicated structure?
No,
I don't want you to recount.
it's not, no, I was just,
Yeah.
I would just had to go back and look at
Yeah.
the list in my head, sorry. So for nurses, it's $136 for RNs and LPNs. However, 26 of those dollars goes to the Healthcare Commission
Okay,
that we have to give to them. For CNAs and GNAs, it's $40, and this is every 2 years.
oh, every 2 years
Every
to
2
renew a
years, that's the
license
cost, yes.
thereafter? Okay,
Yes.
okay. And what is your proposed fee raise?
We actually talked about that, the board meeting this
Okay.
morning.
Okay.
And so the board members want to get a list together, and once we do, I'll be happy to share that with you as well.
Yeah.
We're also thinking about the constituents, and especially in this time of everything rising at one time. We don't want to do everything, just raise it enough, and then maybe if we're allowed to raise it again in a couple of more years, because we understand that factor, but we still just want to be able to take care of our constituents with enough staff. So,
Sure,
yes, so I'll be happy to share
Yeah.
that.
Particularly when you consider the nursing shortage. Not only do you have the shortage in your department or in your board, but in addition, we're very much aware of the ongoing nursing shortage and in health occupations as well as a whole, so.
Yes. So I
yeah.
am working on several committees, including the Workforce Committee with Ms. Link, as well as the Department of Labor,
Okay.
working with both of them as well.
Okay, well, thank you so much again. Appreciate
Thank
your
you,
time.
Senator Gao.
Thank you. I now have Senator Kramer and Senator Reedy.
Thank you, Madam Chair. I'm just going to be quick. I was going to say, listen, I think you've got a lot of sympathetic legislators on this committee who are very concerned about the lack of response from, I think, the administration during the past several years with regard to certain requests. But we are a policy committee, and it sounds like what you're looking for are needs to be filled by the budget committees. And, I mean, our committee chair comes from the budget committee, and she might be able to give you a little guidance in that regard. But I'm not sure that our ears are the right ones to be hearing the concerns, as valid and meaningful as they are. So, following up on the chair's, I think, initial questions about, do you have anything drafted and have you reached out to? And it sounds like maybe we do have a new administration, so you
Yes.
got to start over, trying to make those relationships and communicate your needs. But certainly, meeting with the folks who handle the purse strings, I think, is very important, and start garnering their sympathies as well, to address your concerns. But thank you for bringing them to our attention.
You're quite welcome. Thank you, Senator.
I was going to add, isn't that so? Thank you, Senator. All right, we'll go to. Thank you, Senator. We'll go to Senator Reedy.
Thank you, Madam Chair. Just curious about, we're talking about the IT issues, and this is something that I've heard from a number of constituents with frustration of literally having to go in person to an office that then is not always basically open, and having difficulty or having to schedule. You talked about the phone system. So I understand the $5 million bill for an IT system. That's not something, we don't have that just lying around. What's the deal with a phone system? Why would there be a phone system that can't handle enough incoming calls?
We added about 30 trunks last year and the year before. The phone system is not the Board of Nursing. That falls under the Department of Health phone system.
Are you just getting more
NEC.
incoming calls than a lot of other health occupations boards?
Yes.
Because you have
I
more
mean,
licenses.
we have 16.
Yeah, you have more licenses. So the $5 million we just heard about, is that, so there was an offer in late 2021 to do that? Or were there conditions and that's why it wasn't like, yes, do it now? I mean,
Well, the original cost was $9 million when I was working with the innovation team, and we definitely couldn't do that. And yes, at one time, the secretary did say that he would cover the cost, but nothing has gone past that time. And then the Department of Informational Technology did a study, as Ms. Link stated, which designated the cost for all of the boards with the final tune of, I think it was $48 million, I
yeah,
believe.
I'm sure it's expensive, yeah.
So that's where the $5 million has come from that.
Let me ask you a policy question, and then I'll conclude. I mean, definitely, if you're sharing information, happy to see as much information as you want to share with the committee that's been
Sure.
talked about already. We do these every 2-year renewals. Is there a reason, considering the workforce issues, that we may want to look at? That would obviously be a policy decision. I know you can't do this, but should we look at whether we ought to have a little longer time between renewals, at least for some of our occupations? I'm asking you just a conceptual question. I'm not asking you to endorse that idea, but
Yes.
we have a huge nursing shortage, as you know.
Yes.
I'm not telling you anything you don't know.
I think we would have to relook at how we do our licenses right now. So for anyone who anyone who was born, in the odd year, they renew their license on the odd year.
Right.
Anyone in even year, they would renew their, on an even year on their birth month. It just seemed to work out easy to remind
Sure.
everyone that when your birthday comes around, it's time to renew every 2 years.
Okay, interesting. I mean, because I'm saying, does it need to be 2 years? Could it be 3 years instead, or could it be, I mean, obviously that would it would change and probably some other things, but I just was wondering about that. So, thank you very much. Thank you, Madam Chair.
You're very welcome. Thank you, Senator.
Okay, thank you. I don't see any additional questions for these witnesses. We have one more presentation from the Board of Physical Therapy Examiners, and that is Ms. Kendall Ellis. Good afternoon.
Good afternoon, thank you, and I have the advantage of going last, so maybe I can address some of the issues and questions in advance. So I'm excited, so thank you. Let's see. If I am doing the down button, oh, see? I've been sitting so long. As a physical therapist, maybe we should all take a deep breath a little bit and stretch. I saw some stretching happening. It's a long time to sit, so I do appreciate your last attention here. But I am going to speak on the Board of Physical Therapy Examiners. And my name is Lori Kendall Ellis, and I am a physical therapist. I am not licensed here in the state of Maryland. I come originally from Connecticut, where I practiced for many, many years and have retirement status there. Also, I am a certified association executive and was very excited when I saw the opportunity. It'll be 3 years coming up in March to become the executive director as chosen by the Board of Directors. So happy to be here and happy to be in the state of Maryland. I also wanted to show you a picture of our wonderful board chair. Her name is Karen Gordis, and Karen is professor over at the University of Maryland in the School of Medicine and teaches one of the doctorate physical therapy programs there. as well as does a lot of research. To level set, as you had heard from Ms. Link, where do we sit in the scheme of things? So we do sit in the Maryland Department of Health. We do sit under the boards and commissions, and we are the Board of Physical Therapy Examiners. We are separate and distinct, and we do have our own budget, our own staff, our own statutes, and our own regulations. But I did want to clarify that what I've heard in my tenure as executive director is a term called small boards. And it seems to be a catch-all phrase. And so I asked recently, what does that mean, small boards? And it means any board that is not the physician and not nursing. So, so in hindsight, I understand, but we do want to really make sure that you all understand that, yes, we may be grouped as small boards in terminology, but we are all separate and distinct boards. So as I work on behalf of our board of directors and I am evaluated and hired or fired at their discretion, I do oversee a wonderful staff of 8. We do have a deputy director who oversees our licensing, our continuing education, our physical therapy interstate compact, and we do have a compliance administrator, and he oversees our 2 investigators as well as any other compliance issues and complaints. And we also are made up of 8 board members. Very importantly, 5 of them are physical therapists, and there are criteria in our statutes as to their requirements. We have 1 physical therapist assistant, and we have 2 public members. At this time, one of our public members is an expert in HR, and she actually served on the nursing board at one time as a public member, so came with great experience. And we have another public member who is a pastor, and also comes, and we value his expertise and his philosophical approach to some of the challenges that we hear about. So we license physical therapists, 2 professions, unlike my colleagues here. So physical therapists have a degree. They have a Doctor of Physical Therapy degree, and our physical therapist assistants, they have an Associate of Applied Science degree. In the state of Maryland, we have 2 physical therapist doctorate programs, and we have 8 physical therapist associate programs. And I do know that there is another school that is looking to perhaps start physical therapist assistant education. We had a conversation briefly with some data collection. A licensed physical therapist, in case you have not come across working with a physical therapist, is a musculoskeletal expert who improves your quality of life. In Maryland, we're very fortunate. We are a direct access state. That stipulates by law that a physical therapist may evaluate and treat patients without restriction and without a physician order. Physical therapists diagnose and treat individuals of all ages, and the goal is to reduce pain, reduce opioid usage, return patients back to work, return them back to their previous level of function, reduce their days in the hospital, and really try to impact the best we can the quality of life and, of course, the expense of health care in a positive way. A physical therapist assistant provides physical therapy services under the supervision of a physical therapist. Physical therapy assistants implement the plan of care that the physical therapist puts in place after they do a complete evaluation, and they are allowed and should be documenting constant communication with the physical therapist, any change in plan, any change in any data. The physical therapist and the physical therapist assistant work as an excellent team to ensure patient safety and patient advancement towards goals. Currently, as of January 1st, we have 9,512 active physical therapy licenses, and we have 200 physical therapy compact privileges. Not licenses, but we call them privileges. There are 33 states that are part of the compact at this time across the nation, And if you have any questions on the compact, I'm happy to answer those. According to the U.S. Bureau of Labor Statistics, employment of physical therapists is projected to grow 18% by the year 2029 from today. So much, much faster than many of the occupational health professions. The Board of Physical Therapy Examiners is engaged in a forward-thinking strategic discussions. We want to ensure healthcare across all of the individuals here in the state of Maryland, and we want to make sure that the workforce trends continue to be positive. The more we gain an understanding of what a physical therapist is, as we're doing today, and encourage those that are interested in healthcare to think about that profession, we can all promote the growth in our workforce as well as the retention in the workforce as well. In 2021, our board conducted a workforce study. It is available on our website, and I would be happy to provide you with copies or recommend that you take a look at it. It was very, very helpful for us to see where the profession is going, and then how do we go back and review our statutes and our regulations to encourage that growth of an important workforce component. A little history. The Board of Physical Therapy Examiners has been around since 1947, Statute 13-201. We have our statute, Title 13, and we have our regulations, COMAR, as Title 10. And our mission and vision is here for you all to read. I know you've been sitting a long time, so I won't read the slide, but basically, and very importantly, we are here to protect the public. So in protecting the public, there's 3 points that I wanted to highlight to the committee today. And number 1 is that we are a gatekeeper, and that's very, very important for a regulatory board. We want to ensure the competence of those that are licensed. So reflecting on the question about 2 years versus 3 years for renewal and the application process, it's there for a very important reason. Number 1, we want to make sure that the person who's applying to be licensed is very competent and has gone through all of the processes that they're supposed to do, to the point where we do have a national physical therapy and physical therapist examination that is administered. The 2 years is very important because continuing professional development needs to be assessed. You would not want to see a physical therapist who got out of school and never received any other training and did not take pride in knowing what the best methodology is to help you rehab the best way. So continuing competence is really an area that I want to underscore. We also have looked at our regulation to update our continuing education requirements, and since 2020, those regulations have not been passed. So we too are hopeful with the new administration that there's an increased understanding of the need for continuing professional development, not just simply skills, but what does it take to work in the healthcare system collaboratively and effectively with all healthcare team members as well as the patients and the healthcare system, i.e. the insurance companies, of course, as we all know. The other way is we have a pathway. So the pathway is the ability for consumers, licensees, systems to file complaints, but the other pathway is for those who want to be licensed to be able to be licensed and do so easily and without barriers. And the third way is access. We are very accessible. We work remotely, we are in the office, we're available sometimes, I want to say it seems like 24/7, but our team is there, and we do have access to professionals both on our board, and we do have those in the public domain that we can access as well. Briefly, because you're the Finance Committee, I wanted to just highlight 2 areas of interest. One is this is the allocation that we have received from the Maryland Department of Health, Department of Budget and Management for fiscal year 2023, and not what the numbers are, but just to see where most of those expenses are allocated. So obviously, the first one is personnel, that's 63%. Operating is next, and then our fixed costs such as rent, electricity, things along those lines are 10%. We too are self-funded. I've provided you with the statute where we also cannot reach out for monies others than what we produce ourselves through revenue. And we do that through licensing, so 85% of our revenue is through licensing and 10% is other. And happy to explain other. But I would tell you it's probably mostly from continuing education sponsors who would like us to approve their education so that when you're renewing, you know that your education will be accepted by the board during the renewal process. We do random audits after renewal, and so if your continuing education does not match the current regulation and you are the 1 to 3% in the auditing capture, then we will proceed from there as to how we're going to resolve those issues. As you've heard, we all do a lot. This is just touching briefly on operations day to day, like any business, and we are a business. We have everything from number one customer service all the way down to HR and public outreach. During COVID and during the crisis, the cyber attack, I wanted you to recognize that we did maintain essential business operations, and those are licensing, compliance, complaints, investigations, and discipline. And all of those were up and running within 48 hours, thanking us very, very much for really our two IT professionals that work with the small boards to make sure that they could get our servers up and running and safely doing so that we could continue. We are 100% technology-based for applications to licensing to renewal. We do not, we are almost paperless at this point. So unlike some of the other boards, we're very reliant on that technology and that technology to be safe and up and functioning. And again, I can't say enough about our team who jerry-rigged the best way for us to continue to be technologically connected. We're still not quite all the way reconnected yet. For public, I just wanted to provide the Finance Committee with an example of our website. We are constantly updating and monitoring our website. It's important that anybody has that information that they need whenever they need it. One example of what you can download on our website is we do have a complaint brochure. So it's how to file a complaint and who can file a complaint and how we'll respond. So if you do file a complaint with us, we have an automated system. When you file that form, you will get a response as somebody will be in touch with you within 24 hours, and we do respond and see what type of complaint and how we can help you or guide you if you're just exploring, is this, are you the right board that I should be speaking to? We do hold open session meetings. Again, the Maryland Act to comply with. I wanted to let you all again know that our meeting link and our call-in number are the same every month. We meet the third Tuesday of every month at 1 o'clock. And would invite you to attend at any time. We would look forward to it. If you'd like to see minutes from past open session meetings, they are on our website and available to the public. And with that, again, please think about the Board of Physical Therapy Examiners. We look forward to partnering with you, with the new administration. We want to be recognized as a valued resource. We're here and available. I've given you my cell phone number so I can be reached at any time. And we certainly do understand how busy you are, so if you have any questions, I'm available now or at any time. So thank you.
Thank you very much. Senator Ellis has a question.
Yeah, thank you, Madam Chair. Thank
No
you,
relation, though, unfortunately, right?
You never know.
You're
Let's
right.
talk after this.
Well, only I know the family changed. It's not really Ellis many years ago, but.
Yeah, thank you so much, Ms. Candelas, for your testimony. The physical therapist, is it only physical therapist that's in your regulatory domain? Any other therapists or?
So the physical therapist and the physical therapist assistant.
Assistant,
Those are
okay.
the two professions that we license.
Okay, yeah, thank you for that. Are physical therapists in their scope of practice, do like dry needling?
Yes,
That's in their scope of practice?
yes, it is. It's a regulation, actually, Chapter 12, right.
Chapter 12. Okay, great, thank you.
You're welcome.
Okay, thank you, Senator. I don't see any additional questions. I just had one very brief question, because we've talked so much about funding and fees and all of that. Does the Board of Physical Therapy Examiners, do you all have a fund balance? And if so, what does that look like in terms of your?
Yes, so yes, we do have a fund balance. Our expenses in fiscal year 2022 were around 900,000. Our allocated expenses were about 1.2. So we did stay very conservative in that area as far as keeping expenses down. So if our expenses were given to us at 1.2 and we used 900,000 of that and our revenue covered our work, we then did have a small balance of a few $100,000 at the end of fiscal year. As far as, if you're also thinking as far as going to a new system for licensing, I did, if you don't mind, want to address that we too received the Do It report, and also it would deplete all of our funds if we were to do that. We have looked into other licensing systems that would include compliance, for an example, in addition to that, and they range about $300,000 versus $2 to $5 million. So we have contacted procurement and asked for them to come and please meet with us to educate us about how to go through large procurement so that we would do it properly. We would like to collaborate with the other small boards because right now we do share a licensing system with many of the small boards. And since we have a lot of these similar processes, we felt that we probably could look for a system that would accommodate us, because many of us are not as multifaceted as the Physician and Nursing Board.
Thank you. Thank you very much for that. I don't see any additional questions for the panel. Let me thank you all for this briefing, for the information. I know we have several pieces of information that have been requested by way of follow-up, so if you can get those to the committee, we'd greatly appreciate it. Thank you so much.
Thank you.
Thank you.
Thank you.
Colleagues, I have just a couple of quick announcements.